The next paper is quantifying mental workload of surgeons performing node procedures by Drs. Zheng, Rieder, Casera, Martinek, Swanström from Canada and Portland, Oregon. Dr. Zheng? Or somebody else?
He's here.
Thank you, Sages, for inviting me to present this project. This is actually a project combining three groups of research. Next slide, please.
You have
oh, okay. All right, sure.
Yes.
Yeah, you can see the UBC surgery department. We do a data analysis and a human factor scientist. And a whole group of people with Dr. Lee Swanson's research team and there's another research team in University of Maryland. And this project is funded by a NOSCAR, a Sages and a Endoscopy funding organization to support this program. A unique approach of this study is we're not looking at the patient, we're looking at the surgeon. We are not looking to the abdominal cavity, we're looking to the human brain and to see what's the cognitive issue of the surgeon related to this node procedure. Okay, we can see, the first one we see that the node procedure had been performed, and everyone in this room probably have a clear idea how difficult it is to control endoscopy, to do a procedure. And if you add a surgical task using this flexible tool, it will be more difficult. And I have great honors to interact with, making interaction with a number of surgeons who do the human cases in North America. And all the surgeon report throughout a conversation with the surgeon, and they report a higher level of mental fatigue at the end of the node procedure. And we also know that overload surgeon might ignore some warning sign during the procedure and making an inappropriate decision in the procedure, which might cause the patient safety issues related to the procedure. So we decided to measure mental workload of surgeon, and we serve to two purposes. The first one, we try to improve the system. If we want to improve the node operating system and measuring the impact on the surgeon itself and the impact on the patient itself, it can be a good steps. And also like to develop some safety training strategy to helping the surgeon to overcome the initial learning curve. And all the research basis on this human factor study, basis on what we understand of the human mental workload of the surgeon. And the approach we take for this study is using the secondary task to assess the surgeon's mental workload. If we're taking the human brain as a CPU of the computer, and we can know that our human brain to processing multiple information at one time, but this CPU have a limitation as well, so we cannot process multiple information at one time. If you doing some daily activities, you take some kind of resource in a green zone. And if the task itself is quite difficult, you're going to require a little more resource coming from your total mental resource. Leave a tiny little bit of a resource responding to some unexpected event. And this also, secondary task approach is trying to testing how much spare mental resource left over from the first primary task. And also we need to know when we design a secondary task, we have to know that the secondary tasks have to be in the same domain as the primary task. So they're going to compete the limited resource. So the secondary task performance are going to indicate how much workload had been taken by the primary task. So here's the video. I like to show the video to give you a little idea what's the setting of this study. And if you click on the right camera here, you're going to see, you can see the surgical task is the primary task. When you're doing a suturing task, at the same time, we display some visual information on the next monitor aside of the primary task. So we require surgeon to, while he was performing the primary task, to identify true signal. And here in this case, the true signal is actually a round corner square displayed on the right upper corner of the monitor. So you have to pay a little more attention to this secondary task. You can see that it's quite difficult. And also when you report your vision detection task, we calculate your accuracy rate and indicate how accurate your secondary task it is, and refer to how difficult it is for the primary task. Can we move to the second? Yeah, next slide. Okay, so this is our hypothesis. We believe comparing a node procedure to a routine laparoscopy procedure, surgeons are going to take away more mental resource concentrating on the primary task. So the accuracy of the secondary task is going to reduce. And we do this study in 2 different models. The first model is dry lab. In dry lab, it's quite simple, just picking out a ring from one end and transport the hand and place the ring to the secondary one. And also we have a little animal model with a pig and gallbladder and putting in the train box. When you see through this, the liver and gallbladder through the scope, it really like an animal model, but it's with much lower cost. You can see this is the first task. This is you perform with this task with a conventional laparoscopy instrument versus a node instrument, and this is a slide. This is the image. You can see when surgeon was performing a node procedure in a hybrid model. You can see that that's the task setting. In the first phase, with the dry lab, we successfully including 9 participants. And in the secondary task, in the hybrid model, we have 10 surgeons signed up, and we divided the surgeon into 2 different groups, expert group versus a novice group. So in the first slide, we can see the primary task itself by counting how many successful rings being transported within a limit time of 6 minutes. Using a laparoscopy instrument, people can transfer about 12 rings within within 6 minutes. But using a node procedure, they can only transport 1.5. And in the next slide, in the next graphic, you can see the secondary task. It's much less accurate when you perform a node procedure. Indicate the primary task take away a lot of mental resource when you're doing a node versus doing a laparoscopy procedure. The secondary task, in a hybrid model, you can see again, when you do the laparoscopy procedure, people can pay a little more attention to the secondary task. And so the accuracy rate is high compared to the node. However, between 2 groups of surgeons is not significantly different when they perform the secondary task. So our discussion is, okay, the node procedure definitely take away a lot of primary mental resource. And using this secondary approach, we are able to quantify that about 40% more mental resource had been relocated to the primary task. And this problem is related to the visualization problem and manipulation problem related to the node procedure. And also there's integration problem between the vision and motion as well. So in order to improve, this is a couple of suggestions we can make in order to improve the node procedure and node system is we're trying to make sure that what a surgical platform have to be stable because they provide a base for you to perform a precisely hand movement. And we suggest that the camera and the manipulator have to be separate. So every time you move the endoscopy, you don't need to remove the surgical manipulator and try to remain the look-forward view as much as possible. They're going to reduce 1 level of mental calibration. And this is the end of my presentation. If I have time to
Thank you.
Thank you.
We'll have time for maybe one question from the audience, if anybody would like to ask about this interesting paper. There's been a lot of discussion at this meeting, too, about burnout and disruption in the OR. Mm-hmm. And if people get mentally fatigued, do you consider that maybe you'll see some acting out by surgeons or maybe disruptive behavior in the operating room?
Sure, yes. We do have one paper describe the disruption event happening in the OR. And we using the video surveillance in the OR and quantify throughout the entire procedure how many percentile the people was getting disrupted, how many times that the procedure was stopped, paused by what kind of reason. We do have paper publication in surgical endoscopy 2 years ago.
Thank you very much.
Thank you.